We are back. Sam Seder on the Majority Report. On the phone, Dr. Michael Osterholm. He is the director of Center for Infectious Disease and Research and Policy. Welcome to the program, Doctor.
Thank you.
And I should also say that you are obviously author of Deadliest Enemy, Our War Against Killer Germs, which was from 2017, and warned about the exact, but the situation that we're in now, just to provide that context. Well, let me ask you this, because I've seen interviews that I saw you on Rogan's show in early March. Just give me a sense of where we are now in terms of how you would have predicted we would be at this point.
Well, once we predicted this was going to be a pandemic, the only model we really had to base it upon is influenza pandemics. Remember, pandemics are worldwide epidemics, and we realized as early as mid-January that the transmission occurring in China surely did mean that we were going to see this person-to-person transmission around the world. Based on, at the time, what we saw for how fast the cases were multiplying, in other words, doubling about every 5 days, that it would take a period of a month or more once outside of China before it would really start to show up in communities. So it would go from 1 to 2 to 4 to 8 to 16 to 32 cases. And that then at that point in late February, early March, we'd begin to see these case clusters, including some hot spots in larger demographic areas, occur around the world, which it did. Now the challenge is beyond that, we don't know how this coronavirus is going to act in terms of an influenza-like picture. If it does, what we could surely expect is we could have an initial set of these hot spots with transmission in countries, but not nearing at all the kind of transmission you'd expect to see with a big peak of cases, meaning that in the United States, for example, right now, our best guesstimate is that anywhere from 5 to 15% of the population has been infected, regardless of where you're at, whether it's in New York, where we've had a great deal of activity, still at most 15% infected there. In many other parts of the country, about 5%. So that the next step is, well, what's going to happen? And there's really several scenarios, but they're all based on the following, and that is that this virus is not going to rest. It is going to keep seeking humans until it gets to about 60 or 70% of the population infected. By that time, we'd have enough infected individuals who would likely and hopefully be immune, that would mean that it would help put, in a sense, immune rods in the virus transmission reaction, so that I wouldn't transmit to people if 70% were now immune, and it would eventually start to die out some. But to get to 70%, where you only have 5 or 15% currently having ever had it, that leaves a lot of people left to get infected. So then how does that play out? Well, if it's like influenza and pandemics of the past, where this new influenza virus emerges, 2 started in the winter of the last 10, by the way, in the world over the last 250 years. 2 started in the winter, 3 started in the spring, 2 started in the summer, and 3 started in the winter of our northern hemisphere. In every instance, the big peak occurred about 6 months after the initial peaks occurred. And so you could say if this is going to be like that, we could surely expect in the fall a big peak of cases. Now, why these early peaks occurred and then went away, we don't know. If you look at these influenza pandemics, it wasn't because of human behavior at the time that somehow changed them. Now, I do believe that what we've done recently is flatten the curve, as the term has become known, to basically hold down cases with our distancing activities. But what it'll do in the future, I think, is still really unclear. The other options are that we could just continue to see the kind of activity we see now, almost kind of a whack-a-mole type thing, where it pops up somewhere, we try to shut it down with distancing, and we keep going on until we get closer and closer to that 60 to 70% infection rate. We could have a situation where it's just slow burn, just constant, just from here on out. But the magic number is going to be that 60 to 70% infection before we see this slow down. Now, the one thing that can change that, of course, is a vaccine. But, that means we're talking at least 16 to 18 months, I believe, before we would ever see vaccine actually researched, approved, manufactured and distributed worldwide to actually have an impact on this. So between now and the next 15 to 16 months is going to be a real challenge for us.
So if the only realistic path for this to end is to get to that 60 to 70% infection rate, is the challenge now from a public health policy and I guess just broadly a public policy to essentially reach a number of, let's say, daily infections that is the highest number possible that could allow for our healthcare system to absorb? I mean, is that essentially the challenge? If you were in charge, if anybody were in charge, it feels like, but if you were in charge of essentially outlining the plan, would that be the strategic goal?
Yes, I think two things. One is, first of all, we've got to have a plan. We can't just assume that we're either going to be in lockdown mode. And this is not just about the economy, because it's easy at that point to assume it's about dollars and cents versus lives. And it's not that. It's about our livelihood. It's about the society that we know. We can't lock down worldwide for 18 or 20 months hoping for a vaccine. At the same time, we can't just let this go willy-nilly, because in fact, when these big increases occur, they really will bring down healthcare systems. There very easily could be millions of deaths. And on top of that, the people who have other conditions will be largely denied access to healthcare because the systems will be under such strain. So that all the other illnesses that we think of will also be compromised in terms of how we deal with heart attacks, accidents, asthma, etc. So what I keep coming back to is what I talk about, threading the rope through the needle. We've got to find a way in that middle ground to say that how do we craft a response that is quickly able to determine that cases appear to be increasing, and we locally, regionally apply distancing techniques to try to slow it down. And then ease off again when we are able to demonstrate that cases are coming down, that the healthcare system has capacity to handle more surge, healthcare workers are protected because there's enough preventive equipment available, and that we can feel confident that we can kind of do what we're trying to do right now. But I think the additional challenge with that is that we know that this disease is very, very different in how it impacts people by age and by underlying risk factors, meaning diabetes, heart disease, certain cancers, hypertension, and obesity. And those people are at a much, much higher risk of having a serious illness and dying. So is there a way to help bring back into everyday life the younger population under age 40, for example, who will have a much lower risk of having a serious illness or and even a fatal case? And with the idea that we're not forcing them back in, but should there be a permissive way that we allow them back in? If they get infected, we want them to not transmit it to others who are in high risk of having severe outcomes. But each time one of those people get infected and recover and develop immunity, which again we're assuming will provide protection, we've put one more rod in that virus transmission reactor that will help slow things down. And that person now not only is not in a position to get infected themselves, but as well as the fact they can now interact with people who haven't been infected and feel confident and comfortable they're not going to transmit the virus to them. So that's the kind of discussion we need to have today, and it's a tough one. We've had tough ones already about deciding who gets a ventilator and who doesn't, and what that means, the life and death decisions. But we also need to have a societal discussion today. And I've seen people say, well, if you let any case happen, you're basically putting the economy over human life. No, this virus is doing that. This virus is very, very capable of continuing to march on no matter how hard we try to suppress it. There will be cases. Look at places like Singapore, Japan, models just months ago of the way to do it to control it, and today they're both in national states of emergency. So our job is to figure out how to thread this rope through the needle and to get us through to what will hopefully be a vaccine with the fewest number of people who are impacted, serious illness or deaths, who we don't overrun the healthcare system, and yet we maintain a sense of society and the livelihoods that we all know we have to do.
So this is going to be too rough, but and maybe you can sort of point out where there's the where the math maybe is not wrong, but really the calculus is wrong. So if the idea is that we need to get to 60 to 70%, that that means that there is an inevitability of X amount of deaths. We don't know what X amount of deaths is, because the variables, is what you're saying, is that if we were to, let's just look at New York City, because that's obviously the densest part, and that's so far been one of the, well, certainly by sheer numbers, the biggest epicenter. But so if we were to basically say, okay, everyone under the age of 40 in good health, you go out, and the idea is that we want to try and get as close as we can to 60 to 70% of infection, with the least amount of deaths, because that's the strongest, or relative to the virus, population that we have, and get there as quickly as we can. So if I was to look at the number of, we've had 15,000 deaths at this point, partly as a function of the shutdown, partly as a function of not having shut down, earlier. Can do you have folks who are sitting down sort of crunching those numbers and saying the high end of what we anticipate would be deaths if we were to do something like put 40-year-olds out there, and the low end is this?
Well, again, I think it comes back to, we don't want anybody to get infected, okay? So what I'm suggesting is, if they do participate in everyday life again, as we once knew, and they do get infected, I'm giving you the consequences of their chances of having a serious illness or dying, their ability to maintain a society as we know it, and at the same time, their situation in terms of, yes, you're right, putting rods in the reaction, but I wouldn't have them go back in it just to put rods in the reaction. I wouldn't do that. I'm just saying that if they happen, they actually contribute to that. If I had the perfect magic wand, I'd freeze everything right now in human and virus time except one thing, and that's vaccine development. And then miraculously, 16 or 18 months from now, we just drop that vaccine in and then let time start again. We can't do that. So what we're trying to figure out is, how do we navigate this? It's like gravity. You might not like it, but it works, and it's going to work consistently everywhere all the time. This virus is going to keep transmitting, whether we like it or not. So our job is to figure out, how can we minimize the number of deaths, the serious illnesses, and the overall impact to society, because I think everyone agrees. I find no one that agrees with the idea that we can shut down society for 18 months and come out the other end and not be a completely changed world in a negative way.
Right.
So what our job is to thread all those together. And I think the most important thing is, just like this discussion right here you and I are having right now, we need to have this discussion to get this started, so that it's not seen as someone who is, has a position that, well, these people are okay casualties. They're acceptable casualties.
Right.
Let them go.
No,
that's not it at all. It's how to have that discussion. And so I think this is why this kind of discussion we're having right now is really important.
Well, and I don't want to be too dogged, but I understand the idea that we want to minimize deaths, but I don't, and that there's an inevitability of infection, but do we really want to minimize? I mean, let's just stipulate that 18 months we will get a vaccine, but I don't know how safe it is to stipulate that, but let's just stipulate it for the sake of this conversation. How
Yep, I agree.
How can we? It seems like there's a little bit of a gray zone in there, in terms of, like, yes, I certainly don't want to say I want people to be infected. I certainly don't want to be infected. But at the same time, we need if we're not going to follow down the trajectory of we're inside for 18 months and all the things that come with that problematically, we need people to get infected on some level, right? I mean, it's inevitable, but the idea is that we probably want to attempt to control which cohorts of our society get infected.
Yeah, I mean, this is exactly the kind of discussion, again, I would say the gray zone, if rheostat-wise, let me make a friendly amendment here. I would suggest that if we can control infection and keeping people out there, I mean, new ways of distancing, for example. Let me just give you one that has been presented to me for my input. What if we brought back Major League Baseball, but there was nobody in the stands? It was only the players and the management that were there, but we televised it. And the people who did the television work were up in the stands itself, isolated. Would that be a new normal? Well, we've never done that before, but could we do that and actually bring back society in a way that, hey, we're all going home and watch our TV today because we got baseball on? Now, this is the kind of thing we're talking about is How can you bring back society where you're actually creatively, I mean, look at what happened to the airplanes. Now, we'd all agree that, I feel badly for the airline industry, but we're seeing airlines that normally would be flying 2 million passengers a day, flying 30,000. Will that ever come back again? I think about how many meetings I went to around the world for a day. I'd fly to Geneva, 3-4 days out of my schedule, jet lag, 1-day meeting, and now today I do it online. And so I think that some of the things we're also talking about is how to more creatively hold back some of what was before. It's not an either or anymore. It's either nothing and we're locked down, or it's back to normal.
I see.
And so what we're trying to do is craft a society, and we're trying to craft a way to move with this virus. And I think you were right on the mark when you said, are we going to have a vaccine? We have to be very careful and say we don't know. We hope we can. Yesterday there were data that came out in the first studies out of China looking at a vaccine in monkeys that were challenged with the virus after they had been vaccinated, and it looked pretty promising. Now that doesn't mean it's coming anytime soon, but I think there's reason to hope. So I think what we're looking for is this kind of creative energy to get us to the end of this so we have that vaccine.
Okay. And